I'm Dr. Maitri, Assistant Professor in Nephrology from Institute of Nephrourology, Bangalore, and Secretary of Winkarnataka. India has been spreading its wings, and just a few months ago, we witnessed another milestone in our journey, and that was the inauguration of the Winkarnataka state chapter. This was formed under the aegis of Win India. The Karnataka state chapter aims to embolden the core values of women in nephrology group at a regional level. We are delighted to have you us at the first academic session of Win India Karnataka chapter. It gives me immense pleasure to host today's session, and it's our honor to have the amazing Dr. Lilian Palma from Brazil to provide her insights on complement-mediated thrombotic microangiopathy. Followed by this, we have three interesting cases from Department of Nephrology, St. John's Medical College, Bangalore, under the able mentorship of Dr. Prashant, Professor and HOD, St. John's Medical College, Bangalore, and Dr. Renuka Satish, Professor, St. John's Medical College, Bangalore. My heartfelt thanks to all the speakers and chairpersons for sharing their valuable time with us today. It's time to start today's session with a presiding address by the President of Win Karnataka chapter, Dr. Renuka Satish. Over to you, Madam.
Good evening, everybody. Thank you, Maitri, for this nice introduction. It is a pleasure to host this academic session of Win Karnataka after its inception few months back. So we have three cases. I think it will be quite interesting to discuss these cases. And I have a pleasure to welcome Dr. Lilian Palma. And it is a warm welcome to you, Dr. Lilian, to this Karnataka chapter of Win India academic program. And we welcome you to India as and when possible. Please do come and visit us as we are fascinated by our Vidhan Soda building. Okay, a warm welcome to all again. And without much time, I think we should start our program so that we finish in time. Thank you very much.
Thank you, ma'am. Our chairpersons for the first session are Dr. Arpana Iyengar, Professor, Department of Pediatric Nephrology, St. John's Medical College, Bangalore. Dr. Anupama YJ, Consultant Nephrologist, Nanjappa Hospital, Shimoga. Dr. Nivedita Kamath, Associate Professor, Department of Pediatric Nephrology, St. John's Medical College, Bangalore. May I request our chairperson to introduce our keynote speaker of today's first session?
Good evening, everybody. It's my proud privilege to be introducing Dr. Lilian Palma to this audience. She is an attending physician in the Pediatric Nephrology Department at the State University of Campinas, and her main area of study is in the atypical hemolytic uremic syndrome and C3 glomerulopathy. And she is a co-founder of the Brazilian atypical HUS and thrombotic microangiopathy study group. She's also the member of International Pediatric Nephrology Association group on AHUS and associate editor of the Brazilian Society of Nephrology, Journal of Nephrology. And we are indeed very fortunate to have Dr. Palma here with us, who is who's an expert in the field, and we all have a lot to learn in this topic, in this ever-changing topic. Over to you, Dr. Palma.
Oh, thank you very, very much. It's an honor to be here and witness this Society of Nephrology with the women in nephrology, especially with this new chapter. And I want to thank you for the invitation of sharing my passion. So this, the thrombotic microangiopathies, and am I able to share the screen? Can you all see my screen?
Yes.
Yes, okay. So it's been really a 12-year journey with the atypical HUS, but it started because of patients. And until today, and yesterday we had a meeting of the International Pediatric Nephrology Association with this consensus in AHUS that we are writing. And we understand that there is a need for an international consensus with state-of-the-art diagnosis in thrombotic microangiopathies and a tool to help people tailor the differential diagnosis, because until today, it is very different among the regions how you deal with the patients with thrombotic microangiopathies and how you make the diagnosis. And I will try in these couple of minutes to share with you my experience in this disease. I have been studying longer time, but more recently also the C3 glomerulopathy. And I will speak a little bit on that too, because it's a relative to the atypical HOS. I have been speaking for Alexian for a long time, more recently also for C3G. This is not a sponsored lecture. I have to say that I was always very free to give my opinions on the lecture, because what makes our opinions are exactly the fact that we see patients. And when we see patients, that gives us a lot of experience, especially in rare diseases, which have been my passion since medical residency a long, long time ago. So where do we start? We start with the need to make the correct diagnosis of this syndrome called thrombotic microangiopathy. That's very important. Every student has to identify these patients. Why? Because they are very severe and it's a life-threatening condition. You don't need to know exactly what's going on, what is the underlying cause, but you need to recognize a thrombotic microangiopathy. And this is made on a triad, usually very ill, sometimes pale, oliguric, and sometimes with edema. That's the way they present most of the time. Then you draw the blood and you examine the patient, and what you see, there is this triad, okay? Anemia, thrombocytopenia, and organ injury. Usually the kidneys are involved, but most of the time other organs are involved as well, like brains, like cardiocirculatory organs, and so on. Sometimes, especially in kids, we see the skin very involved with necrosis of the fingers. So this triad, anemia, thrombocytopenia, kidney injury, high suspicion for thrombotic microangiopathy. Why high suspicion? Because there may be some other differential diagnosis like sepsis, like aortic valve replacement, like sometimes lupus and so on. So you need to rule out secondary causes, especially by medical history, and then you end up with this kind of finding in the lab. It's not any anemia. You need to recognize that this is a microangiopathic hemolytic anemia. Therefore, there are further exams that have to be collected. Haptoglobin, LDH, and above everything, look at the smear to see if you can find fragmented erythrocytes or schistocytes. Then you open up three big groups. One group is thrombotic thrombocytopenic purpura. I'm not going to speak a lot about this, but I'm going to give you just a hint on the bedside for the ones who are not really familiar with this. The other one, of course, is the most common one, and we see it all the time here in Brazil, and especially in Argentina, where it is very endemic, is the STEC HOS, or the typical HOS. And then you're left with this huge group, which are the secondary causes. And after you rule out secondary causes, you end up with what we call today atypical HOS. Some of these patients will now be classified as complement-mediated HOS, okay? So the first thing we need to rule out is TTP. Percent of mortality of patients with thrombotic thrombocytopenic purpura happen in the first 24 hours. So you need to have a bedside rule to make this diagnosis. Why does this happen? Because you have a lack of this enzyme called ADAMTS13. For a long time, we used to call AHOS or HOS/TTP. It was all mixed up. And then from 2 decades ago to now, we already know that the pathophysiology is completely different. So the lack of ADAMTS13, which is this enzyme that cleaves this huge von Willebrand factor, happens through congenital anomalies. So you can have it genetically gone, or you can have autoantibodies against ADAMTS13. 90% are autoantibodies. So it happens more in young females. It's an autoimmune disease. And once you don't have the ADAMTS13, every time you have the huge von Willebrand factor anchored on your endothelial cell, it will trap platelets. Therefore, that I find very useful on the bedside. And the main findings here that I want everybody to remember as a rule of thumb is every time you have severe thrombocytopenia and the kidney is not so severely involved, the chances are that this patient has TTP. And even if you don't have ADAMTS13, you start plasmapheresis immediately in the next 6 to 8 hours. I have seen patients pass away because we left the plasmapheresis for the next day. So it is a medical emergency. Then the second cause, and I don't know, I would love to hear how this is in India. I bet that you have STEC there because we also have it here. It's tropical, country, lots of diarrhea. And what happens is that some people, when they have the diarrhea by E. coli or some other sugar toxin producing bacteria, they develop typical HUS or STEC HUS. What we call a patient with STEC will have HUS, only 50%, 15%. So it's a small proportion, but when they do, they get very ill. And what happens is that usually 2 weeks after that, they start having this paleness, oliguria, and so on. Usually it's a kid, needs dialysis most of the time. And usually the platelets recover in 1 week and the kidney starts recovering in 2 weeks. Nevertheless, these are patients that have to be followed up because they end up with hypertension, proteinuria, and some of them even progress to end-stage kidney disease and go for transplants. We can talk about that if you will, and I would love to hear your experience on this too. Why does this happen? Because the toxin binds to a receptor called GB3 that is very rich on the endothelial cell of the kidneys. It goes inside the endothelial cell, binds to the ribosome, and then it kills the cell there. So once you have this endothelial cell damaged, what happens is that you will start, and this thrombus here will destroy the red blood cells, provoking all the triad that I showed to you: low platelet, anemia with a microangiopathic characteristic, and also kidney ischemia, therefore kidney injury. But it is an auto-limited disease. So once you get rid of the toxin, you have the bone marrow cells redoing the endothelial cell layer, and these patients usually recover. STEC is the main cause of thrombotic microangiopathies in children, but it is followed closely by atypical HUS, which is something that sometimes we don't have in mind. We start looking at the more rare diseases. I have seen all of them. We can also exchange some ideas on them if you want. I have seen patients with cobalamin deficiency, DGKE, congenital TTP, and so on. But the most frequent after STEC is atypical HUS. And why is to make this diagnosis? Because we have the treatment, okay? So atypical HUS, what is it? It is a defect in the alternative complement pathway. So to make it simple, the alternative complement pathway is part of the innate immunity. It's always ready to destroy bacteria. How does it work? In blue, we see the proteins that are going to build the membrane attack complex, which is a perforin. It will go through the membrane of the bacteria. In order to come back to its basal state, you have the counter-regulatory proteins, either in the blood, like factor B, factor H, which are the most important ones, or attached to the endothelial cell, like MCP or thrombomodulin. So you have a very, very straight control of this alternative complement pathway, in terms that it will only get amplified once you have an invasion by a bacteria. In atypical HUS or complement-mediated TMA is a defect in the counter-regulatory proteins. It can be an autoantibody, but most frequently you have a genetic defect in any of these counter-regulatory proteins. And once it gets amplified, you no longer have it coming back to the basal status. The formation of massive amounts of membrane attack complex will not only destroy bacteria, but will also damage the endothelial cell. And we have seen what happens when you have the endothelial cell damage, is like we saw in STEC, but with a different pathophysiology. You have a detachment of the endothelial cell. This is very important once you look in the biopsy. Maybe in the electronic microscopy, you see those endothelial cells swollen or detached. That is a sign of thrombotic microangiopathy. And because our organism will understand that there will be a bleeding, it makes a thrombus. You will have the destruction of the red blood cells, schistocytes, consumed because it's an intravascular hemolysis, and you will have elevated LDH because of hemolysis and because of ischemia. And of course, you have a thrombi here, you have thrombi here, they will attach platelets. And there comes the triad: anemia, thrombocytopenia, and organ injury. The importance of thinking about complement-mediated TMA is because we have now for more than a decade a complement inhibitor. It is easy to use a complement inhibitor. It is very difficult to make the diagnosis of atypical HUS. I have some experience with eculizumab. We still do not have ravulizumab here in Brazil, but how does it act? It will block C5 exactly at this point, preventing the formation of the massive amount of the memory attack complex. Last year, we published this review in pediatric nephrology about TMA in children, where we discuss all these differential diagnoses, but I felt like there was something missing when that is a checklist in order to make the diagnosis of TMA, evaluate the degree of organ injury, and then you go to the differential diagnosis. And this is something that I find a little useful, at least for the bedside, because what I see it that sometimes it's a little scattered. One physician remembers Shiga, the other one remembers Adam TS13, and sometimes in the timeline of the patient, this takes a longer time for you to make the correct diagnosis of the underlying disease. Remembering that atypical HOS or primary or complement mediated is the last one after you ruled out everything. Look at the path that we need to go through in order to make the diagnosis of atypical HOS. You have to rule out TTP stack that I already mentioned and all the secondary causes by medical history, by physical examination, and by dedicated exams to each one of these causes. And sometimes this is enough to make you make this diagnosis of atypical HOS very far away, and maybe sometimes the kidney is gone. So I have seen patients that take 2, 3, 4 months to say, no, I think this patient has AHOS, but the kidney is already gone by then. So is there something that can make this diagnosis a little faster? That's what I want to brainstorm with you in the second half of the lecture now. What do we have now, and what are my thoughts on how to handle with this situation, okay, to make this diagnosis a little earlier. We know that kidney biopsy is not the answer, because as I show here, and this is from a pathologist here in Brazil who was very generous to share with me, we see that different causes, including lupus with TMA, eclampsia, AHOS or STEC, or so on, all of them present the same pattern with thrombi in glomerulus and sometimes thrombi in the vessels. When it's a transplant and you have mediated antibody-mediated rejection, you can have C4D. Most of the time, you don't have that in the native kidneys. So there was thought, can we detect C5b-9 in the immunofluorescence of these biopsies? Will this be useful? Well, my thought is that this is useful to show that there is massive complement involved in that condition, but it is not enough to differentiate one cause from the other. As we can see here, kidney allografts and native kidneys, AHOS, you can have C5b-9, but also in lupus, also in post-bone marrow transplant. So it's not a specific marker for AHOS, but it rather shows you that there is a lot of complement involved, and maybe this patient will benefit from complement blockade. The other tool that we have, and also I would like to understand from you how this is nowadays there in India, are genetics. We always sought to run after genetics for HOS. And now we know that almost half of these patients will not have genetic testing. I will discuss this a little bit, so we can brainstorm a little bit on this genetics. So these are the data for the international registry with over 800 patients, 44% negative findings, and they were enrolled as being patients with atypical HOS. So then I sought all the publications that we had over the world to see how the positivity runs, and it's very different. Overall, it's 50 to 60%, but you can see that it can be as low as 18%, as high as 80% in Japan. So it's very population driven. So this is the rule number one. When we talk genetics, we need to know how genetics are in our own population. You need to know your population. And this has been very pungent and very active in India with groups that are studying thrombotic microangiopathies. And I don't know if all of you are aware, but India has the highest prevalence of anti-factor A in the population, especially in young adults. And we did not see this in any other population in the world. So bottom line here is, the more you know genetics in your population, the easier it is for you to incorporate this as a tool to put on the puzzle, because AHOS, the diagnosis is made based on a puzzle with clinical conditions, history, exams, genetics, biopsy, and so on. So everything together will lead you to the correct diagnosis, or at least the most appropriate diagnosis for this patient. And just as an anecdote, in December, I was in Pune for a congress. And then while I was doing a lecture, I saw this beautiful sunset from my room, and I took a picture, and then I realized that there are the colors of your flag. And now I understand where the flag comes from. So it was a beautiful venue for me to see the sunset in this green area there in Pune. We also have data from Brazil. So there is this Brazilian registry. It's a preliminary report with only 75 patients. Nevertheless, we saw that 66% of the patients have positive genetic testing. Most of them are factor H and factor H related proteins. We did not have patients with MCP or CD46, which is different from most of the population. So that's why, bottom line here, and I think this paper that is recent from Dr. Anuja Java from the USA shows us that genetics is not written in stone. It has to be a dynamic process, the interpretation. What did they do here? They picked up 76 patients with both TMA and C3 glomerulopathy, and they reanalyzed their genetic data according to functional studies. And when they did functional studies, they saw that some patients who were previously classified as having variants of unknown significance, which in the bedside is very difficult for you to deal with. What are you going to do with this information of VUS? And she saw that half of them were reclassified as pathogenic. So I always say, when you have a genetic testing that is undetermined, you have to go back to the clinical case and see exactly how the patient is. If it is a recurrent pattern of hemolysis or HUS, or recurrence after transplantation, then you need to consider this as a pathogenic variant, because the patient itself has the phenotype that we are talking about. So just to wrap up before I go to the end of this lecture, this was a review that I wrote during the pandemic. And I thought to myself, I'm going to make a review of all the literature regarding genetics and secondary causes of TMA, because this is something that puzzles. Okay, how can you have a patient with severe TMA and has lupus? Do you treat with complement inhibitor or not? How do you handle with that? And we saw papers from the 1900 on, okay? They're very interesting papers down there, back there in 1900s. And what did we conclude? We have the primary TMAs, TTP and AHUS. And as I told you, around 50 to 60% of patients with AHUS will have a positive genetic testing. Among the secondary causes, it is variable. So patients with malignant hypertension and TMA are the ones who are pretty much alike AHUS. Infections also seem to be a trigger of AHUS more than the cause for the TMA. But when it comes to drugs and autoimmune diseases, this is lower. So in drugs, for instance, we see that less than 1% of patients with TMA have positive genetic findings. And this is very interesting, because what we need to do here is remove the drug. And if we take a look at the American apheresis paper, drug-induced TMA is level of evidence 1A for plasma exchange, because probably you also have not only the direct toxicity of the drug, but also autoantibodies against this drug leading to the TMA. This is something that is still under debate and has to be studied. One assay that I like a lot, and I think that maybe with adaptations we can use worldwide, is this in vitro study of endothelial cell culture. So the endothelial cell culture, you put the blood of the patient there, the serum, and you see if there is deposition of membrane attack complex C5b-9 on the endothelial cells. What did they find? First group was from Professor Rimuzzi and Marina Norris in Italy. First thing, this box here are the normal volunteers. So they saw that irrespective of the mutation, and even in patients with no mutation detected, they have the deposition of C5b29 much higher than the normal volunteer. So it seems to be a very active complement deposition disease there. Even when you don't have overt TMA, which means overt hemolysis. You think that the patient is more of a quiescent phase of the disease, and they show that even in these patients, you have a lot of complement going on. We don't know exactly what that means. In this paper as well, what they saw is that the relatives of these patients with AHOS that were healthy carriers, did not have the disease. When they looked at the deposition, it was higher than the normal volunteers. So we also don't know what that means in terms of cardiovascular disease and so on, and morbidity. But this is something to be followed up. And more, they also saw that this deposition can be shown in patients with secondary TMA. And this has already been used in the practical grounds to differentiate the patients who might benefit early of complement inhibition because they have evidence of a lot of complement deposition, like for instance, this paper from the Netherlands, that in malignant hypertension with TMA, the patients with C5b29 deposition received also complement inhibition besides blood pressure control. If they were negative to the deposition and genetic screening, they only did the hypertensive emergency control. And they saw that these patients that usually don't go well, they had a better evolution in compared to blood pressure control only. Okay, but as I say, it's not every patient with malignant hypertension, it's malignant hypertension plus TMA. And just to finish this thing that I have been working on for a while, and I hope that we can conclude this upcoming year, that is the study of the proteomics in complement on thrombotic microangiopathies. Where did this come from? It came from a brainstorming with the people from Mayo Clinic, where I went for a rotation a couple of years ago. And I said, it's very difficult to differentiate AHOS from secondary causes. Can we take a look at that? So in short, what is this method? It's a laser dissection of the glomeruli. This glomerulus goes through mass spectrometry, and then you have a list of more than 800 proteins. So you need to have a very, very experienced professional doing this. And you receive it like this in a decrescent amount of what we called total spectral count. So the protein that has the higher prevalence are the ones who have the higher TSC. We saw that among 12 patients with TMA. These patients had VUS, some of them had pathogenic variants, and some of them did not undergo genetic testing because they come from outside Mayo Clinic. This was done in Mayo Clinic. And what we saw is that, as expected, C3 was very high, followed by the counter-regulatory proteins. We can see here, especially CFH. But it was a surprise to see that there are some classical pathway proteins involved. Also, the patients who had pathogenic mutations had higher spectral counts than the patients who had VUS or who were not tested. So maybe this is a path for us to understand a little bit the pathophysiology and also the role of the classical or lectin pathway in these patients. We already know that there are some proteins in the lectin pathway that can be involved in AHOS. And also there are inhibitors of lectin pathway, MASP2, that are being developed. We also saw that it is different among the of TMA. Look at the green one. I'll call you to look at the green one. Exactly the drug-associated TMA. Most of them were gemcitabine. You see that the C3 in the drug-induced was very high. So it's a potent TMA, very high complement deposition, very low genetic screening. And this is important for us because should I give complement inhibitor to these patients? Probably not. You need to remove the drug. Sometimes you do pheresis. Most of the time they will respond. And this is different from the other causes of secondary TMA. We also compared, and this is very interesting for us to brainstorm a little bit, patients with secondary TMA, atypical HOS, compared with C3G. And let's look only at the green bars today, okay? Green bars are C3. You see that in C3 glomerulonephritis and DDD, C3 is much, much higher on patients with AHOS and secondary TMA. So even though these two diseases share some of the pathophysiology, probably the complement inhibition that works for TMA does not work for C3 because you need to handle this huge amount of C3 in the C3 glomerulopathies. And that's why more recently there was a change in nomenclature, because before it was DDD or MPGN type 1, 2, 3, and now the IF is more important than the electronic microscopy to define if you have a complement mediated or immune complex MPGN or the C3G, where you have predominance of C3 on the biopsy over immunoglobulins. This made a huge difference in the treatment of these patients. And there is this more recent paper that this group divided these patients with MPGN into clusters. And I want to call attention to this cluster 4, that are those patients who present the features of thrombotic microangiopathy. When you look at the previous, the original presentation of them, the end-stage renal disease prevalence is the same. But when you divide by clusters, you see that this cluster 4, that are the patients with C3G, who also have TMA features, they don't go very well. So we publish a case series, and it was just accepted. It will come out now in Kidney International reports, of this overlap syndrome between C3 and thrombotic microangiopathy. So it seems that there are some patients with the complement involved in such a level that the phenotype they present can be mixed with MPGN and thrombotic microangiopathy. And how to treat these patients in the future, where do you block the complement, is something still under debate. This is my last slide. Okay, this is how I see thrombotic microangiopathies. You need to identify these patients. Once you identify, there are all these cases that we've been through, and I didn't go into details for a matter of time, but each one of these can be a matter of a different lecture. But always have in mind that if you treat the underlying disease and the TMA still ongoes, or the kidney is ongoing, or there is a relapse after transplantation, this patient may have atypical HOS. We still don't have the gold standard to make the diagnosis, but as I told you, this is a puzzle where everything matters: history, physical examination, how the patient behaves with the pattern of relapses or not, and also all these complement assays that I showed you. And I want to thank my Brazilian group for, we've been together for more than a decade. More recently, I have been, especially for the proteomics. Stanley is a pathologist here in Brazil with a huge experience, and he's been part of the BAF group with TMA post-transplant. And finally, our Committee for Rare Diseases in the Brazilian Society of Nephrology, that has been very active in spreading the word of atypical HOS around Brazil and Latin America. Thank you.
That was an excellent talk. Dr. Linian, you are such an eloquent speaker, and you made a very complex topic sound so simple, because you organized your thoughts and your slides in such a way that it brought a lot of clarity to probably clinicians who don't see atypical HOS as often as pediatric nephrologists like you and me would encounter. So we have a couple of questions. I would request Dr. Nivedita, my colleague, who's also a pediatric nephrologist, read out those questions. I think you brought out a lot of commonalities between the two countries, besides both being low middle income countries and tropical countries. I think you've shown that you see STEC HOS more often, and I must say that we don't see STEC HOS like the way we used to see probably 2 decades back when I just started my career in nephrology. With regard to atypical HOS, yes, as you said, the anti-factor H antibodies are more common. So we send those titers, but we start off on plasma exchange, waiting for those titers. And in Some occasions we get those negative results for antibodies, and then many of our patients do not go ahead with genetic testing because they just can't afford. But I think the main work of Indian HUS is from All India Institute of Medical Sciences Pediatric Nephrology Department under Dr. Arvind Baga's leadership.
Yes.
So all the data from India is from that center. And they have shown that 50% of our kids have anti-factor H antibodies. And they've shown that there's a variability in the panel of genes in those who have negative antibodies. So let's look at the questions. Over to Nivedita.
Thank you, Dr. Lillian, for that very impressive talk. And as Dr. Arpana said, you made it really simple, though clinically it may not always be such a simple patient to approach. And in pediatrics, probably it's a little easier because we can easily rule out a lot of things like malignancies and pregnancy and other things. But if it happens in the adult, it may be a different question altogether. We do have a lot of questions in the chat box, and but before that, I would like to take this opportunity to ask one question of my own. You put in COVID in your list of investigations, and that is very interesting. So could you please tell us, because influenza is definitely known to be an important risk factor and several other viral infections. Could you tell us if you have had any experience with COVID-associated atypical HUS?
I had, and it's terrible. You can have COVID as a trigger of AHUS. We saw that the patient needed eculizumab because she did not improve from hemolysis, and that she ended up having a positive genetic testing. You can have COVID itself driving the TMA. First, they thought it would be antibody anti-ADAMTS13, then they ruled that out. Then the second thing that started with electronic microscopy, they saw some COVID capsules inside the endothelial cell, and they thought it was a direct toxicity. This somehow, it seemed, because they didn't see the damage of the endothelial cell, only the virus inside the cell. And then they came up with complement. So it seems to have a lot of complement involved in the TMA, caused directly by the virus. So once you get the virus treated or the patient recovers, you see the TMA going. These patients always are the ones who are really good to have the genetic testing, because as I told you, infections are a powerful trigger, and it's important for you to understand if they have or not an underlying condition there that can relapse. Okay. Regarding the treatment, there are some NIH trials of complement blockade in COVID-driven TMA. The results are variable because some patients are very severe and they end up passing away. But I think there's an ongoing trial there to try to respond if these patients would benefit or not. Okay. My point of view is that every time you have a life-threatening TMA, you started plasma, the patient is not responding, you should consider complement inhibition. How long you're going to treat is a matter of debate. I'm not sure if every patient needs to treat for the rest of the life, especially if the genetics is negative. But I think it's what we have today that can prevent death and kidney damage.
Yeah, thank you so much. I'm not sure if anybody in India has seen that, and I think it's one more thing to rule out. Especially when we are having these waves of COVID as an etiology for HUS. So thank you for that, sharing your experience. We have one question from Dr. Shashikant, which asks you if acquired atypical HUS, is there any place for plasma exchange and immunosuppression?
Yes, there is.
Age?
Yes. These are the ones. I have a patient, adolescents especially. It's amazing how you don't see much adolescence in the registries, okay? So I have one recurrent pattern of TMA. She always responds to plasmapheresis. There are publications with the use of rituximab and also immunosuppression. So definitely yes, especially if you can follow the titer.
Thank you. Another question is, would you recommend genetic testing for all patients with malignant hypertension and TMA?
I don't know if all patients, if you take care of the blood pressure and the patient goes back to normal or near normal and does not have a TMA again, I don't think this patient needs to undergo genetic testing. I recommend genetic testing every time there is a risk for end-stage organ damage. You know, even STEC patients, if we think about, because it's not so easy, it's not so common to STEC to lead to end-stage kidney disease and a transplant, okay?
Yeah.
Usually it's self-recovered, but sometimes these patients go. I've seen one the day before yesterday, a 15-year-old kid to STEC. I talked to the parents. I said, even though it was STEC, we think it's very important to rule out AHUS, because the worst thing you can have is a recurrence after transplantation. Every time you do this diagnosis of a recurrence, sometimes you don't have time to rescue the kidney graft. So if you have a high suspicion there's something not going on well, this patient is not answering the way I wanted or expected, then yes, definitely the genetic testing will be helpful.
In the same context, another question I had was that, like Dr. Archana mentioned, most of our patients are anti-factor H antibody positive, and you showed the data as well. But so we get by in most cases with just plasma exchange initially and then with immunosuppression, and most of our patients luckily do well. But is there a cohort of them that we should do genetic testing in? We cannot afford to do genetic testing in everybody, though there may be some predisposition, genetic predisposition even to anti-factor H antibodies, some polymorphisms. But who should we select out of this cohort to target to a genetic test?
The ones who progress to CKD or end-stage kidney disease, absolutely the ones who will go to kidney transplantation, then you need, because it's going to change a lot what to expect and how you will approach the transplant. I have seen patients recur inside the operative room. Once the kidney graft was, the anastomosis was open, the patient started having hemolysis in the OR. And it's an emergency because the kidney gets black. You lose the kidney very fast. There are two situations in where the kidney is gone, is post-pregnancy and post-transplant. These are violent TMAs. So I think for transplant candidates, always. For the ones who are progressing with CKD, that the creatinine is going high, there's something going there, hypertension. Haptoglobin is a good marker because it's cheaper. So if you see that the patient, you think he's doing well, but haptoglobin is very consumed, there's something active going on there. I had a patient like that. She was well, we didn't know what was going on. Haptoglobin for 2 years in dialysis was undetectable. And then we started her on eculizumab after 1 year, fighting and running after the drug. I started her and she was going to transplant with a relative. After the first dose of eculizumab, haptoglobin normalized. So that showed that she had chronic hemolysis in dialysis, not active hemolysis, but chronic hemolysis there, So these are the ones that you know that they're not doing well. Hypertensive, creatinine progressing, and for sure the ones who will go to transplant.
I see Dr. Sanjeev Sethi joining us. Welcome, sir. What a privilege to have you on board today. He's got a question for you, Dr. Lillian. Why is there more C3 deposits in C3GN versus atypical HUS?
He could answer that. Well,
exactly.
The main pathophysiology of C3 glomerulopathy is a defect in the C3 amplification. So it's not a terminal complement pathway disease. It's a proximal complement pathway disease for different reasons. C3 NEF is definitely something important there, much more than we see in TMA, but also some genetic defects in specific portions of the gene. And you have this amplification going uncontrolled and a massive amount of C3 and the products making their deposits in the membrane. And then you have the leukocyte infiltrating, and in order to protect itself from the leukocyte infiltration, the kidney creates this double contour membrane. And I learned that from Dr. Sethi himself. But what I think is that you need to address C3 because the papers that use eculizumab for C3G are the ones who didn't have a good response. So you need to block the complement a little bit upstream, okay, for the C3G. We don't know if blocking upstream will do well for TMA2, but definitely for C3G, you need to block C3. And there are drugs being developed for that that are already, you know, in the pre-marketing condition. I'm very hopeful that we have that because it's also a devastating disease that recurs after transplantation. And we see that the patients lose the kidney function very quickly with C3G. But thanks for the question.
I think we can take one more question. This is a question that asks when plasmapheresis is not urgent in TMA. So is there any situation where you need not start plasmapheresis urgently?
If you have eculizumab. No, if you have high suspicion for STEC, then of course, what I recommend, and I think it's very important to say that, okay? One of the most important things is to have a local consensus because I saw a lot of mentions there that we don't have eculizumab, access is very difficult. I know it's a country with, 1 billion people. It's not so easy to get a high cost drug and say, now you're using everybody, okay? But if you have a consensus, you can put priorities in the use of these kind of drugs, and you can understand exactly when to do the genetics, who are the people you need to do plasmapheresis. So of course, we will not do plasmapheresis in TMA that it's STEC, because it has no reason to be. Literature, it doesn't work. But if you have drug, that's the first line treatment. If you suspect of TTP, it's a first line treatment. So overall, when you're in doubt what's going on and you cannot rule out something that is treatable, you start plasmapheresis. It can be life-saving. Sometimes it's not kidney saving, but definitely it's life-saving. And I think it's an urgency. We have to treat TMA as an urgency. That's why I think that checklist is very important. So you make sure that you collect everything, that you understand which organs are really damaged, and then you take it from there. Okay. I think that would be my final message. Attempt to make a local Indian consensus in AHUS so everybody speaks the same language around a very difficult situation. Much easier said than done.
We do have a consensus for HUS for low resource countries. And as you rightly said.
For low income countries,
yes,
for what? For low income countries.
Yeah.
And it's based on plasmapheresis. Is it based on pheresis?
Yes.
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 Yes. Yeah, that's it. That's it. Pheresis saves lives.
Thank you so much, Dr. Lillian. It was wonderful interacting with you.
Thanks to you all, congratulations for this wonderful attitude of the women in nephrology. And I'm really, it's very lovely to see you together seeking for knowledge and for helping patients. And you can always count on me. I'm in deep love with India, and I am programming myself to try to go to Calcutta. Is that how you say? Calcutta in the end of the year. I think for the Indian Society of Nephrology, I'll try to be there. Okay.
Thank you so much, Dr. Lillian, for speaking to us about complement-mediated TMA. We really enjoyed your presentation, and we appreciate you making time in your busy schedule to speak to us about this topic. Thank you again for your time. We see Dr. Sanjeev Sethi here. Warm welcome to you, sir. If you could speak a few words and grace the occasion.
Okay. Can you hear me?
Yes,
hello.
Sir. Yes, sir.
Okay,
please.
thanks. I'm getting ready to work. So it's a wonderful talk. My only thing from the pathologist standpoint, I don't know, this thing keeps popping up on my iPhone, is that I think AHUS in general tends to be more catastrophic, so presents with rapid onset, and it's typically more of a localized small vessel story. So as a result, you see less C3 in that, which always surprises me because there's so much complement activation in that disease, as you know. On the other hand, C3GN or DDD tend to be more fluid phase, tend to be more chronic, And that's why you see low C3 levels very often in association with C3GN and DDD compared to AHUS, where the C3 levels don't drop in spite of activation of the complement pathways. So C3GN and DDD tend to be fluid phase abnormalities in circulation with C3NF, as Lillian just said, and so it tends to be more chronic, more progressive, don't do so well, and you get tons and tons of complement deposition in the end organs, particularly the glomerulus. AHUS, on the other hand, tends to be more localized, tissue phase instead of fluid phase, tends to be more quick onset, rapid onset with antibodies to factor H versus C3NF, which is more chronic. So I think that's the way I look at AHUS versus C3GN. And of course, the abnormalities, as Lillian said, is upstream, tends to be more upstream and more chronic. But it's a fantastic talk. I really appreciate being part of this and listening to Lillian, and I'll listen to the other speakers as well. Congratulations on this effort. It's a fantastic program you built together within a few weeks, I think. Thank you for having me listen, and thanks.
Thank you so much, Dr. Sanjeev Sethi, sir, for joining in. Thanks a lot for your insight. Moving on, due to short of time, we'll start with our first case presentation. Interesting case. The chairpersons for this session are Dr. Manisha Sahai, Professor and Head, Department of Nephrology, Osmania Medical College, Dr. Arpita Ray Chowdhury, Professor and Head, Department of Nephrology, IPG MER, Calcutta, Dr. Manjusha Yadla, Professor and Head, Department of Nephrology, Gandhi Medical College, Hyderabad. I request the chairperson to kindly introduce the speaker and the topic.
Yeah, thanks, Maitri. I think that was a brilliant talk by Dr. Lillian. So anyway, we have to move on. So we have an interesting case being presented by one of the senior residents, Dr. Naveen from Department of Nephrology, St. John's Medical College, Bangalore. He's going to speak to us an interesting case scenario of proteinuric illness in pregnancy. Is it always preeclampsia? Generally, we think that a proteinuria in pregnancy is supposed to be preeclampsia, but there are some other illnesses that we are supposed to know, whether it's an underlying chronic glomerulonephritis or an autoimmune disease or probably comorbidities such as diabetes and hypertension. So let's listen to him in another 10 minutes and then we'll have the discussion on the case. Over to you, Dr. Naveen, for sharing your presentation. Naveen.
Good afternoon, ma'am. I'll be starting presentation.
Please share your screen.
Good afternoon to everyone. I am presenting a case of a 23-year female who is married for 2 life in her 3rd gestation at 26th week. She presented to us with complaints of bilateral lower limb swelling since 5 days, facial swelling and periorbital swelling since 3 days, and swelling of genital area since 3 days, decreased urine output since 2 days. Since her prior pregnancy, her history dates back to her prior pregnancy. I would like to give history from her first pregnancy. She had first pregnancy in November 2021. At the 6th week of gestation, she noticed that she had an edematous illness, for which she was evaluated at a local hospital, where nephrologist had reviewed her and renal biopsy was done. After doing renal biopsy, she was started on oral steroids. In view of no response after 1 month of oral steroids, she was advised for MTP. At this time, she didn't have any history of hypertension, hematuria, joint pain, oral ulcers, photosensitivity, or skin rash. She responded to steroids in 6 to 8 weeks, and after which the steroids was tapered and stopped. Steroids were tapered. She responded by February and stopped by month of April. She had an unplanned pregnancy in March 2022, but had an abortion due to fall. Present pregnancy was allowed after consultation with the treating nephrologist, LMP being 22nd of June 2022. There was no history of proteinuria and she was normotensive in her regular ANC visits. She had iron and folic acid supplements, and fetal viability scan, which was done in her ANC visit, was told to be normal to her. Now she presented on 1st of Jan to us in her 26 weeks of gestation with history of edematous illness since 5 days. She also gives history of frothy urine and decreased urine output since 3 days. This time she didn't have any history of hematuria, headache, blurring of vision, or abdomen pain. Past history, no similar episodes during childhood. There is no past history of jaundice. She is mixed by diet and no addictions. Menstrual history, age of menarche being 16 years, regular menses. Her last menstrual period being 22nd of July 2022, and expected date of delivery being 28th of March 2023. So summarizing the case, here is the 26-week gestation, third time pregnant, presenting to us with edematous illness during her first pregnancy, for which she underwent renal biopsy and was advised to do MTP in view of persistent proteinuria, responded to oral steroids. Presently in her regular ANC visits, there was no proteinuria and was normotensive, now presenting to us with anasarca in her 26 weeks of gestation. Can I go ahead?
Yeah, should we break in with some questions, or we would proceed till the diagnosis is made?
Madam, we'll finish the case, madam, so that we understand the case thoroughly. We'll finish the case. Dr. Naveen, can you finish the case presentation?
So the provisional diagnosis at the end of history was the 27 weeks of gestation in her third pregnancy, presenting with adult onset nephrotic syndrome. Probable differential diagnosis being preeclampsia, podocytopathy, lupus nephritis, and IgA nephropathy. So the differential diagnosis points in favor of this and points why did I consider these diagnoses. Preeclampsia, because it is the most common cause of nephrotic syndrome in pregnancy. Here in my case, there was onset of proteinuria after 20 weeks of gestation. There was prior history suggestive of glomerular pathology in the first pregnancy. Points against it is response to oral steroids in her first pregnancy. My second differential diagnosis is podocytopathy MCD versus FSGS, because she is presenting as anasarca and her response to oral steroids in her first pregnancy. But one doubtful history which goes against it is a history of elective MTP during her first pregnancy. So, which brings me to thought of two more differential diagnoses: lupus nephritis and IgA nephropathy. Because lupus nephritis being most common connective tissue disorder in female, and history of, as the nephrologist had advised to do MTP, because maybe the nephrologist had a biopsy finding of more aggressive disease or a proliferative disease. So that is the reason why MTP was advised, maybe thought of to keep these two as a differential diagnosis. But however, there is no extrarenal features, and the patient was normotensive during her pregnancy. Can I go with examination?
Yeah.
Yeah, please finish the case, no? Then we can have the discussion.
On examination, blood pressure was 130 by 70, pulse rate being 74, weight being 65 kg. There was pitting type of pedal edema, sacral edema, periorbital edema, vulval edema was present. For abdomen examination, fundal height was midway between umbilicus and xiphoid notch, corresponding to 28 weeks of gestation. Fetal heart sounds were present. Other systemic examinations were normal. Fundus examination, there was no evidence of hypertensive changes. Urine dipstick examination, there was 4+ albumin. Sugars were negative and no sediments. So diagnosis after examination, here is a 27 weeks of gestation in a third pregnancy, adult onset nephrotic syndrome relapse, probably it was a podocytopathy. Other differential, until investigations are available, I'd like to keep as lupus nephritis and IgA. Examination. Can I go further?
Yeah, please finish the case. No, we have two more cases to go. So let's finish the case, have the discussion. No?
So we had investigated her. On her investigation, blood counts, CBC was normal. Renal functions were normal. She had a severe hypoalbuminemia, albumin being 1.2 and proteins 3.7. She had a dyslipidemia, raised cholesterol, LDL and triglycerides. Urine routine showing 4+ albumin without active sediments. urine protein creatinine ratio was 17. ANA was negative, C3, C4 was within normal limits, viral markers were negative. Fetal USG and uterine artery Doppler was done, which showed normal single live intrauterine gestation of 28 weeks, normal uterine artery Doppler flows. So we got the biopsy of the first biopsy done during her pregnancy, which was done outside, which showed light microscopy showing 8 glomeruli, one showing segmental sclerosis. Rest of the glomeruli was normal. Tubules and interstitium were normal. Mild hyperplasia of tunica media and intimal thickening was there. IF showing 5 glomeruli, one being obsolescent, negative for deposits. So the impression given by the pathologist was FSGS, not otherwise specified. So course in the hospital, she was given IV albumin infusion with intermittent IV diuretics. Started on Visalon 50 mg per day. Patient urine output improved with resolution of edema. She was on low molecular heparin for thromboprophylaxis and aspirin. She was also on vitamin D and calcium supplements. Follow-up in OPD, she responded to oral steroids. Her urine routine albumin was traced and spot urine protein creatinine ratio had become 0.1 after 2 weeks and serum albumin was normalized. Fasting blood sugars and postprandial blood sugars were normal. After 4 weeks of 50 mg Visalon, the dose was reduced to 40 mg per day. Presently, she is on 40 mg per day Visalon without proteinuria and albumin being normal.
So the final diagnosis is Dr. Naveen. Final diagnosis.
After the investigation is adult onset nephrotic syndrome with relapse in her 20th weeks of gestation in her third pregnancy. But this one histopathology being FSGS, not otherwise specified.
Are there any pictures of the electron microscopy that is done?
And this biopsy was done outside. We couldn't access the biopsy slides. It was not done in our hospital. So she had come from a remote area. She had come from a hospital from Andhra, so we couldn't access that.
Since we had the underlying suspicion of a proliferative glomerular disease, did we do any serological evaluation?
Serological evaluation for ANA was done, and C3, C4 was done, which was normal.
Okay. Madam Arpita, Madam Manisha?
Yeah. Myself picking up Dr. Nadeem for a few questions. Dr. Nadeem, would we proceed with few questions?
Yes.
Yeah. So a nice case indeed. And you explained it nicely, put up the differentials. What do you think if you don't have the history of previous AONAs in the pregnancy, and now you are looking at this lady with proteinuria, adult onset nephrotic syndrome at the end part of the pregnancy, what else you think you'd bring up, and how these two types of diseases, the preeclamptic disease and the other proteinuric illnesses related to glomerular disease, they differ in monitoring and management during pregnancy. So 2 questions. One, you have no lead from the other pregnancy. So in this pregnancy, how you will look at this nephrotic syndrome, if it is the first one. And second part is, how do these diseases differ in monitoring and management from the PET group of diseases? And can there be any overlap? The third question.
Yes. Ma'am, any pregnant patient who is presenting with anasarca and proteinuria for first time after 20 weeks of gestation, our first differential diagnosis should be preeclampsia, because it is most common cause of nephrotic syndrome, and it is the most common cause of nephrotic syndrome in pregnancy. And usually this preeclampsia associated nephrotic syndrome, once the placenta and the delivery has happened, usually it resolves with the delivery. And patients,
Dr. Nadeem, you have
yes.
already given us the investigations, urine routine, everything. So with all the reports in hand, sparing the biopsy, because that came from previous and we ignored the previous, what would you decide? Suppose the magnitude of proteinuria. Do you think 17-gram proteinuria is very common with preeclampsia?
No, ma'am. Usually,
No. So
nephrotic range can happen, but severe proteinuria is less likely.
Is less likely. So that was one point. The severe dyslipidemia that was accompanying, that was a signature of full-blown nephrotic syndrome, those are also not very common in PET. Rather, the target organ defining things
Yes.
are more important to be monitored in PET. Na?
Yes, ma'am.
So there might be even overlap too. One
Yes.
glomerular disease patient, previously known as IgAN or FSGS, and having again 26 weeks pregnancy, can have a relapse and simultaneous can have hypertension. It's
Yes.
very difficult there
Yes.
to say that how much is for PET and how much is for glomerular disease. Why it is important?
The existence of previous glomerular disease can worsen the mortality, pregnancy mortality, and fetal mortality also. If there is a pre-existing glomerular disease, upon that,
PET can also do that. PET can also do that. It
but
can, maternal and fetal outcome both may be affected. How do we monitor in these two diseases? In PET group of diseases, we do not monitor the magnitude of proteinuria.
Yes.
But here we keep on monitoring the 24-hour urine protein to look at the response of some immunosuppression that we use. In PET, the magnitude of proteinuria is not that important. So we manage hypertension, we look for other organ affecting signs, and we stay tight on that. We just check that whether urine albumin strip testing is usually adequate in monitoring. But when you suspect a glomerular disease, it is important to go for at least urine spot PCR monitoring as recommended by last 2020 or 2018.
Yes.
Can I ask a question,
American
Dr.
Hobbs group. Yeah.
Yeah, so Dr. Naveen, nice presentation and an extensive discussion has already gone by, and I don't think we have too much time. So one question from my side. You have entertained SLE as well. So you mean the first pregnancy was SLE nephritis and this pregnancy was SLE nephritis and lupus was quiescent in between without any immunosuppression? So that's point one. And what's the lipid profile in SLE? Do you get hyperlipidemia in SLE, or SLE is characteristically defined by absence of hyperlipidemia?
First question I would like to take. SLE presentation can present from a nephrotic syndrome, nephritic, and it has a wide range of presentation. And the thing is, I got the SLE to the differential diagnosis because after the biopsy, the nephrologist then had advised for a termination of pregnancy, which indicate there might be, because sometimes the clinical picture of the SLE may not match the histological picture.
I understand, but between the two pregnancies, what was the gap between the two pregnancies?
Between the two pregnancy, the gap was
how many years?
1 year.
8 months was there.
8 months. So in between, the SLE was quiescent without any immunosuppression. If it were to be
less chances.
Okay, fine. And what about the lipid profile in SLE generally? Lupus nephritis, nephrotic syndrome, nephrotic, nephritic. What's a typical lipid profile? That high dyslipidemia is
less likely seen in this one, SLE lupus nephritis.
What was the blood pressure of the patient in the second
blood
pregnancy?
Was, when I examined, it was 130/70. 130/70.
Okay, but she fitted into the definition of preeclampsia as compared to her previous blood pressure, right?
So that's why you considered preeclampsia as the first diagnosis.
Yes, ma'am. Because sometimes the previous there may be masking of hypertension during her first 2 trimester, and so that the reason that is the reason why there may be masked hypertension which can be there. And first being the glomerular etiology in the previous pregnancy, we don't know what type of glomerular etiology it may be, and we don't know the exact creatinine values before. So keeping this in mind, how there may be a masking of hypertension during her pregnancy. So that is the reason I had kept this differential diagnosis.
Sorry, Dr. Nadine, after examination, if you don't document hypertension, without proteinuria, PET diagnosis is acceptable now with other target organ damage evidence. But
Yes,
without hypertension, no diagnosis of PET.
PE.
Have to document hypertension.
Yes.
Yeah, I think as we're running short of time, Dr. Naveen, we are running short of time. I think there are a lot of inputs and a very interesting and exciting case, of course. So definitely we need to think about an underlying glomerular disease, probably a non-proliferative. Our basic focus is on maternal progression and of course the control of the proteinuria and the fetal well-being. As Dr. Arpita has pointed out, it may not be a preeclampsia and it must be an underlying glomerular disease because she doesn't fit into preeclampsia as such exactly. So the focus is basically on the maternal and the fetal surveillance. I think probably you can give us a follow-up later if you don't have it now. So thank you so much. Since we are running short of time, I thank the co-chairs and the presenter, Dr. Naveen as well, and hand over to Dr. Maitri for the further proceedings. Over to you, Maitri.
Thank you so much, Dr. Naveen, for the wonderful presentation. Thank you, dear
Thank you,
chairpersons. Going on to the next case. The case 2 will be chaired by Dr. Susina Alexander, Professor, Department of Nephrology, CMC Vellore, Dr. Swarnalata Guditi, Professor, Department of Nephrology, NIMS, Hyderabad, and Dr. Priya John, Consultant Nephrologist, AIG Hospitals, Hyderabad. May I please request the chairpersons to introduce the speaker?
Yeah, good evening. It's a very excellent talk and a great discussion going on. So let us now move to the second case. Second case will be presented by Dr. Prajwal, Senior Resident, Department of Nephrology, St. John's Medical College, Bangalore. And he'll be discussing on the skin lesion with renal failure, treated as leprosy, twist of tail in heart of granuloma story. So over to you, Dr. Prajwal, for the interesting case.
Madam, my slide is visible, ma'am.
No, the one stop sharing the screen. No, Dr. Naveen, please stop and Dr. Prajwal restart.
Madam, now we are able to see.
Yes, go ahead.
Put in slide share.
Presenting a case of 44-year-old male manual laborer from Bangalore. He came with chief complaints of skin lesions all over the body since 4 years. History of presenting illness. 4 years back, he came with whitish, scaly, raised skin lesions in the extensor surface of bilateral forearm, measuring approximately 3 into 4 centimeters. There was no history of pain, itching, ulceration, reduced sensation, or hypopigmentation. He had taken medication prescribed by a local doctor for 2 weeks and it was stopped, the details of which was not available. Over a period of 2 years, the lesion gradually increased in size and it started to involve the entire extensor surface of the arm. It involved both flexor and extensor surface of the legs and thigh. It also involved the back, abdomen, neck, ear, and scalp. He also noticed few raised lesions in the bridge of the nose, below the eyes and cheek. There was no history of itching, photosensitivity, joint pain, or oral ulcers. History of intake of herbal medication for 1 month, following which he doesn't report any change in the lesion. And few of the lesions healed with hyperpigmentation and scarring, and new lesions appeared in the same areas. Also, there were few reddish, nodular, painful lesions in the lower limb, which appeared occasionally, and it used to subside over a period of 3 weeks. There was no history of lower limb swelling or facial puffiness. no urinary symptoms, no flank pain, passage of stones in urine, no anorexia, fever, or weight loss. In November 2021, that is approximately 2.5 years after the onset of skin lesion, he was evaluated by dermatologist and skin biopsy was done from the right forearm, and he was diagnosed to have leprosy. He was treated with 2 drugs, rifampicin and dapsone. Rifampicin he received on the 1st of every month and dapsone he received daily. Lesions improved and the medications were stopped after 6 months. In September 2022, that is after 4 months of stopping the medication, he reports that the similar lesions reappeared and he was again consulted a dermatologist and he was started on rifampicin and dapsone. 3 weeks after starting the medication, he developed painful nodules in the lower limb, which ulcerated, measuring 3 into 6 centimeter in the right lower limb. For this, rifampicin and dapsone was stopped and he was started on steroids. And he was told that the ulcer was infected and he received IV antibiotics for a period of 15 days. Steroids were tapered and stopped over a period of 6 weeks. 3 months after the ulceration, he developed lower limb swelling up to the ankle. He did not have urinary symptoms or facial puffiness at this point of time. And he was evaluated for the lower limb swelling and he was told to have a creatinine of 2 milligram per deciliter. Hence, he was referred to nephrology for further evaluation. On further questioning, he had history of headache, holocranial for a period of 10 days, photosensitivity, redness and itching of the eyes. He had history of constipation and had an approximate weight loss of 10 kgs over the last 6 months. He was also told to have hypertension during this visit and he was started on 2 classes of medications. There was no history of nausea, vomiting, diminished vision or Zika symptoms, no abdominal discomfort or melena, no testicular pain, no history of dyspnea or chronic cough, no history of weakness in both limbs, reduced sensation or deformity in the limbs. Past history, no history of diabetes or tuberculosis in the past. He consumes a mixed diet, no habits. Summarizing the history, 44-year-old male with no known comorbidities came with complaints of chronic multiple scaly white plaques all over the body of 4-year duration. He was diagnosed to have leprosy after 2 years of the onset of lesions and was treated with rifampicin and dapsone. His lesions improved with treatment. However, 4 months after stopping the treatment, he developed worsening of the skin lesions and he was restarted on rifampicin and dapsone. After restarting rifampicin and dapsone, 3 weeks later, he developed nodular lesion, which later ulcerated and was treated with antibiotics and steroids. Now he came with a 10 days history of headache, redness, itching of eyes, weight loss, lower limb swelling, hypertension, and renal dysfunction. There was no history of oliguria, joint pain, reduced sensation, or deformity. With this history, I would like to consider a diagnosis of acute nephritic syndrome, infection-related glomerulonephritis, immune complex-mediated glomerulonephritis, secondary to leprosy, leprorelation type 2, erythema nodosum, leprosum. Points in favor of IRGN is a short history of edema, hypertension, and renal dysfunction, and he had a history of infected lower limb ulcer and immune complex mediated glomerulonephritis. Again, the syndrome being acute nephrotic syndrome, and it is found in around 10 to 15% of leprosy patients with the renal involvement. Shall I proceed with the examination, madam?
Yes, please. You can complete your presentation. Then after that, we'll have discussion.
General physical examination. He was conscious, oriented, moderately built and nourished with a BMI of 24 kg per meter square. Pulse was 80 beats per minute, regular. Blood pressure was 180 by 100 millimeters of mercury. No asymmetry or postural drop. Affable at the time of examination. No pallor, edema or lymph nodes. Local examination. He had annular plaques in both the forearm surfaces, largest measuring 16 to 3 centimeters. And you can also see a healed lesion around 2 into 3 centimeters, shiny and scaly. Similar lesions in the lower limb with hyperpigmentation. Few of the lesions are healed with scarring. Lesions are both in the extensor and flexor surface and also in the knee joint. In the right lower limb, there is a healing ulcer with the granulation tissue with multiple hyperpigmentation and scaling. This is similar lesions found in the foot. Also, he had a scaly lesions in the scalp as well. This is a lesion in the scalp. And he had healed hyperpigmentation, hyperpigmented patch in the left forehead. Also, you can see the hyperpigmentation healed in the bridge of the nose, and there is also one lesion in the cheek. Also, he had lesions behind the ear, also scaly white lesion. Touch pain temperature were normal in the areas of skin lesion. There was no evidence of nerve thickening. There was no deformity. Systemic examination was unremarkable. Fundus was not visualized due to presence of posterior synechiae. This is the slit lamp examination. It is showing asymmetrical pupil with the synechiae formation in both the eyes. Urine routine albumin trace, nil RBCs, WBCs 42 cells, no WBC cast. At the end of history and examination, I would like to keep a diagnosis of acute kidney injury, acute interstitial nephritis secondary to leprosy. Points for interstitial nephritis are patient is non-oliguric and he had use of multiple drugs like rifampicin, antibiotics, and also the presence of steroid pyuria. However, the points against interstitial nephritis is the presence of hypertension, new onset, which is currently unexplained at this point of time. The previous two diagnoses considered after the history, IRGN and immune complex mediated GN, there was no proteinuria or RBCs in urine. So at the end of examination and urine, I would like to keep interstitial nephritis as my diagnosis. Investigations, hemoglobin of 15, urea was 32 and creatinine was 2.28, electrolytes were normal, albumin was 4.54, no transaminitis, serum calcium was 14.8, urine routine showed albumin trace R0 W42, urine protein creatinine ratio was 0.58, complements were normal, ANA was negative, viral markers were negative. Ultrasound abdomen showed right kidney 9.6 centimeter, left kidney 9.7 centimeter. There are multiple intrarenal calculi, largest measuring 0.5 mm, and there was mild splenomegaly 13.3 centimeter. So at this point of time, summarizing all the positive findings, he had extensive skin lesions, weight loss of around 10 kg over last 6 months, creatinine of 2.7, hypercalcemia, which could now explain the hypertension, sterile pyuria, renal calculi, mild splenomegaly, and the ophthal evaluation showed granulomatous uveitis. So putting all together, we thought of a diagnosis of sarcoidosis in a patient with previously diagnosed leprosy. So next we started evaluating for other evidence of sarcoidosis. We got a chest X-ray which showed a mediastinal lymphadenopathy. CT chest was done, which showed largest lymph node being 2.9 centimeter in the right hilum, and left hilum lymph node is 1.7 centimeter. There is also a pretracheal lymph node measuring 1.88 centimeter. The same sections you can see the multiple renal calculi present, and also there was mild right hydronephrosis in the right kidney. So serum ACE levels was 144.7, which was almost 3 times the upper limit of normal. PTH was suppressed 6.53, vitamin D levels was 14.9. So reviewing the skin biopsy, which was done in November 21 outside, the biopsy report showed papillary and reticular dermis, shows several granulomas composed of epithelioid cells and Langerhans type giant cells. Epidermis was normal. White stain was negative for AFP. However, this section did not include any nerve. Based on this report and his skin lesions, he was treated as tuberculoid leprosy in November 2021. So with hilar adenopathy, elevated ACE levels, other evidences for sarcoidosis was there, and we made a diagnosis of sarcoidosis in this patient. So final diagnosis, aka akin stage 2, prerenal hypercalcemia and possibly interstitial nephritis secondary to sarcoidosis. Treatment, he was started on 1 mg kg steroids, 60 mg, and hypercalcemia was managed conservatively with saline hydration. It was planned for degestanting later after 3 weeks. Follow-up, after 3 weeks of starting steroids, his creatinine has come down from 2.2 to 1.1, and calcium had reduced from 14.8 to 9.6.
Yeah, thank you, Prajwal. It was an interesting case. So the initial diagnosis was made wrong as a leprosy. You mean to say the whole, the essence of your presentation. Is that so?
Yes, ma'am.
Okay. So, like initially, was it tested for this lepra bacilli? It was only made by diagnosis was made based on the tissue reaction, and there were no bacilli seen in the what you
Yes,
call
madam. The
stadium.
biopsy report did not show any AFB, as well as nerve also was not there. Based on the
Okay.
skin lesions, he was diagnosed to have leprosy.
Okay. But is it possible that we may get so much of skin lesions in sarcoidosis before the other organ involvement is seen?
Extensive skin lesions are rare, ma'am, but it is possible. Few case reports are there with extensive skin lesions, and sarcoidosis is also one differential diagnosis for leprosy.
Okay. And what do you think is the reason why he responded initially to the rifampicin and dapsone?
Dapsone also acts as an anti-inflammatory, madam. So probably skin lesions would have might have got better with that. But as we can see, when he presented, he had extensive lesions. So it is not, even though he gives a history that skin lesions got better, when he presented, he had extensive scaly lesions. So I'm not sure, ma'am, whether it actually improved, because we had not seen the patient after the treatment.
Okay. So interesting case. Over to the other chairpersons, please.
Yeah, hello, I'm Susina here. Just a few points. I hope I'm audible.
Yes, madam, you're audible.
From your case history, it was almost very evident that it was Hansen's disease. And then when you went on to investigation, you showed us that the urine protein was negative. There were no RBCs and there was only WBCs. And then you showed us that there was bilateral renal stones.
Yes.
But we did not have any reports of urine culture.
Urine culture was negative, madam, in this patient.
Okay, because one of your differential was interstitial disease based on the presence of WBC, but pyelonephritis did not figure in your differential diagnosis. Probably that also could have been made as it was a pyuria, and there was a history of, and there was findings of renal stones bilaterally.
The diagnosis was at the end of examination, madam, and he did not have any symptoms of fever, dysuria. So I did not consider at the end of history that he would have a.
No. After the exam, after your findings, after your investigations, you revised your diagnosis, right?
Yes, madam.
Yeah. The other thing is, did he have a split skin smear?
No, madam. This time it was not done.
Could you tell us why it was not done? Because you will expect split skin smear to be done for all Hansen's disease. So was there any reason why it was not done?
Yeah, he stayed with us only for around 2 days, madam. So he didn't have, because of financial constraints. So we got all the investigations done, and he was planned for a split skin smear by a dermatologist. But all the evidence was pointing towards sarcoidosis. So we planned.
Now, if I'm going to turn around the case and I'm going to tell you that this is still lepromatous or borderline tuberculoid leprosy, which is mimicking as sarcoidosis. Because leprosy can mimic sarcoid. You can have hyaluronopathy. You can have all the other features that you have described. And you can have a response to oral steroids, even if it is interstitial nephritis caused by leprosy. So if I'm going to tell you that this is all still leprosy, and leprosy is mimicking sarcoid, how will you justify yourself?
Madam, the other findings, usually, madam, leprosy, the skin lesions, it usually involves the skin, and the lesions are not found in the scalp. The scalp lesions, because it usually involves the colder areas of the skin. So scalp lesion was there. So that is why the dermatologist opined
But
that.
you have not even done a split skin smear. And scalp lesions are seen in leprosy. So without doing a split skin smear, sarcoidosis essentially here is a diagnosis of exclusion. So when you have completely excluded leprosy as an etiological cause, only then can you even consider sarcoid, because leprosy is a great mimicker, just like tuberculosis. So you can have all features of sarcoid. They will even respond to steroids. But
Madam,
it may.
In this patient, there was no hypoanesthetic patches, or there was no nerve involvement also, madam. And when we had reviewed the biopsy report, in that also there was no AFP, and as well as there was no nerve lesions there. So
nerve lesions where in renal biopsy?
No, madam, the skin biopsy which is done. We have a skin biopsy.
Yeah, but nerve lesions are not mandatory in lepromatous. Yeah, not mandatory. So I think you need to really rethink on whether it can still be leprous Hansen's, which is mimicking a sarcoid, because you have all the other things. Because when you have an infectious agent which is so obvious in causing the disease, and you had treatment, then to go back and say it's sarcoid, without ruling out completely Hansen's will be a little difficult to justify. But I'm happy that you thought about both the differentials, and your presentation was quite good. So all the best.
Thank you.
So 1 minute, can I step in, Dr. Susina? Just a comment. Dr. Priya, before the ACE levels were very high, Dr. Susina, in your experience as well. The ACE levels can be a little higher in leprosy, but will it be as high as 100? I think he has mentioned, 100.
Yeah, ACE levels, again, we have found that it's not very specific.
Yeah, it's not specific, but as high as 100 is, I think it's more.
Yeah, it's a little, there is yeah, but that's not diagnostic of sarcoid, but still, yeah. It could be a differential, yeah.
Priya, over to Priya.
Thank you, Prajwal. That's an interesting case. I have one question. So was hypercalcemia and hypertension was not there when leprosy was diagnosed? And yes, second one was not there?
Hypertension was not there, ma'am. He was newly detected to have hypertension when he presented to us in January.
Okay. And could it be related to dapsone? Because as we see now, Dr. Susina has rightly said, it could be an overlap. So could we think about like drug related? Could it be dapsone related?
Dapsone was stopped 3 months back, ma'am, before he presented. After he developed that ulcer. Ulcer was 3 months before his presentation to us. So rifampicin, dapsone, all the drugs were stopped 3 months before he presented to us, ma'am.
Rifampicin?
Yes, madam.
Nephritis. Okay, but it can still occur, right? 6 weeks. They say 6 weeks to 8 weeks later. So I think drug related also you need to think if you're not giving importance to ACE levels alone. Yeah. Thank you, Prajwal.
Thank you, Prajwal. That was an interesting case, really mind-boggling whether it was sarcoid or leprosy. Thank you. I thank all our chairpersons. Moving on to the last case for this evening. The last case is chaired by Dr. Srilata, Professor and Head, Calicut Medical College, Dr. Priya Pius, Department of Pediatric Nephrology, St. John's Medical College, Bangalore, Dr. Priyamvada, Professor and Head, Department of Nephrology, JIPMER, Dr. Isha Tiwari, Assistant Professor from MGM Super Specialty Hospital, Indore. I request the chairpersons to kindly introduce the speaker.
Yeah. Good evening, everyone. So the next case will be presented by Dr. Nitin, Senior Resident, Department of Nephrology from St. John's Medical College, Bengaluru. He will be presenting a case of severe hypertension with renal failure, a pulse diagnosis. So Dr. Nitin, we are already running short of time by almost close to 25 minutes, so kindly stick on to time. You can proceed, you can finish off the case in a single go so that we can have some extra time for discussion.
My slides are visible, madam?
Yes, your slides are visible, you can proceed.
Presenting a case of 49-year-old female housewife from Bangalore, currently admitted for evaluation of renal dysfunction. History of presenting illness. I would like to begin my history from 2014 onwards as it is relevant for her current presentation. She presented with headache, bifrontal, pulsating, more in the early morning, relieved on taking paracetamol. There was no history suggestive of aura, seizures, sweating or palpitations. That time she was diagnosed to have hypertension and started on single class of antihypertensive drug, the detail of which she does not remember. Cause of hypertension and target organ involvement was not evaluated at that time. She was on regular follow-up every 3 months outside and compliant with her medications as per her history. No improvement in her headache was noticed and her blood pressure was not controlled. Antihypertensives were increased. Drug details she does not remember. In September 2021, after 7 years, however, she does complain of her headache on and off, but it was relieved on taking paracetamol tablet. She was evaluated for her chronic headache. Her blood pressure was 180 by 100 millimeter of mercury, and her medications were changed to telmisartan and amlodipine. Creatinine was 1.5 milligram per deciliter. There was no history of decreased urine output, no history of bilateral lower limb swelling, hematuria, cola-colored urine, frothy urine, or lower urinary tract symptoms. There was no history of fever, sore throat, arthralgia, rashes, or oral ulcers. In December 2022, on routine follow-up, she had blood pressure of 200 by 110 millimeter of mercury, was informed to have serum creatinine of 2.5 milligram per deciliter. For control of her blood pressure, dose of telmisartan was increased along with amlodipine and diuretic was added. Ultrasound of kidneys were done and was told to have normal size kidneys and was planned for renal biopsy. Later, after a week on evaluation, she had a blood pressure of 190 by 100 millimeter of mercury and creatinine to be 4 milligram per deciliter and hence was referred to our hospital for further evaluation. There was no history of lower limb swelling, hematuria, frothing of urine, no history of blurring of vision, vomiting or seizures, no history of chest pain, sudden onset breathlessness requiring admissions. There was no history of over-the-counter intake of analgesics or any alternative medications. There was no history of fever, malaise, arthralgia, rashes or oral ulcers. There was plus minus history of claudication of bilateral lower limb and right upper limb. However, there were no telltale signs of ischemic pain. Past history gives history of depressive maniac episodes since 2 years. Is currently on amitriptyline and escitalopram. There is no history of type 2 diabetes or tuberculosis. Personal history, mixed diet, normal appetite, there are no addictions. Obstetric history, para 2, liver 2 and no abortions, normal vaginal delivery, no history of any pregnancy complications, no history of pregnancy-induced hypertension. Last childbirth was 20 years back and last menstrual period was 2 years back. Summarizing the history, 49-year-old female, non-diabetic with history of poorly controlled hypertension since 8 years, requiring multiple class of antihypertensives, including ARBs, detected to have renal dysfunction 1 year back with creatinine of 1.5, now presented with worsening headache, hypertension, and renal dysfunction, serum creatinine 2.5, which has worsened to 4 in a week, without history of edema, hematuria, or frothing of urine. I would like to consider provisional diagnosis of acute and chronic kidney disease. Acute factor being accelerated hypertension or drugs, ARBs or diuretics. Chronic cause, however, based on the history, it is I'm not sure about the compartment involved. However, I would like to consider the diagnosis of chronic renal parenchymal disease, that is chronic glomerulonephritis, renovascular hypertension, or benign hypertensive sclerosis. Points in favor of chronic glomerulonephritis is as the history is suggestive of resistant hypertension, renal parenchymal disease is more common and the patient is having hypertension and renal dysfunction. However, points against is no history of edematous illness or no history of hematuria. Renovascular hypertension, because there is early onset of hypertension, uncontrolled blood pressure requiring multiple drugs, there is history of worsening of renal function with ARBs, and there is history of plus minus history of claudication pain. Benign hypertensive nephrosclerosis also I would keep it as a last diagnosis, as diagnosis of exclusion, as there is chronic hypertension with stable renal function up until she was started on ARBs and diuretics, after which the creatinine had worsened. Points against, however, is uncontrolled hypertension with 4 class of drugs and recent worsening on increasing of ARBs. General physical examination, conscious, oriented, moderately built and nourished, height 165 centimeter, weight 70 kgs and BMI of 25.7 kg per meter square. Pulse rate was 100 per minute, felt in the regular in the left radial artery. However, on the right side, all the peripheral pulses were not palpable. The left side carotid was feeble, and brachial and radial artery was palpable. Blood pressure was palpable only in the left upper limb, which was 180 by 100 millimeter of mercury. It was not recordable in other limbs. Right subclavian bruit was heard, abdominal bruit was heard, and bilateral renal bruit was heard. There was no pallor, no cyanosis, clubbing, or edema, and JVP was not elevated. Local examination, skin, there are no trophic changes, no hair loss or nail changes, no muscle atrophy, no digital ulcers in the limbs. Temperature was warm to touch. Systemic examination, cardiovascular systems, S1, S2 heard, there were no murmurs. Respiratory system, normal vesicular breath sounds, no adventitious sounds. CNS, conscious, oriented to time, place, and person, higher mental functions normal, and no focal neurological deficit. Per abdomen, soft, non-tender, no organomegaly, and bilateral renal bruit was heard. Fundus, there was grade 1 hypertensive retinopathy. Urine routine, albumin was trace, and no active sediments. Diagnosis after examination, I would still shift on to acute on CKD, acute factor being accelerated hypertension or drugs, and chronic cause renovascular hypertension, most probably Takayasu arteritis. Coming to investigations, hemoglobin was 8.4, CRP of 1.55, ESR of 63, creatinine of 4.58, sodium 139, potassium of 4, total protein of 7.14 and albumin of 3.81. Calcium, phosphorus, and PTH of 7.9, 5.03, and 184 respectively. Transferrin saturation of 18%. Urine routine, albumin trace, and no active sediments. Urine PCR of 0.7. C3C4 was normal, and viral markers were negative. Ultrasound kidneys, right kidney was 9.2 centimeter, left kidney of 9.1 centimeter with grade 1 RPCs and maintained corticomedullary differentiation. 2D echo, there was concentric LVH, no RWMA, and ejection fraction of 58%. DTPA renogram, both the kidneys were subnormally perfused and showed subnormal excretory function. High background activity suggesting bilateral renal parenchymal dysfunction. And EGFR of both kidneys, left was 41% with 20 ml per minute, and right was 59% with the GFR of 29. Carotid Doppler, the circumferential wall thickening of the right common carotid artery and subclavian artery stenosis. Axial section of showing the arch of aorta and dilatation of the arch of aorta with circumferential wall thickening. Sagittal section showing full course of the aorta, where we can see multiple aneurysmal dilatation and narrowing of the vessels in the descending thoracic aorta as well as in the thoracic terminal aorta, along with stenosis of the superior mesenteric artery. This is the axial section showing the right common carotid artery and the right subclavian artery. We can see that there is complete occlusion of the right subclavian artery, showing no opacification. This is the axial section of the abdominal aorta showing circumferential thickening of the aorta along with narrowing of the aorta. Axial section near the bifurcation of renal division of renal artery showing severe renal artery stenosis near the ostium, as well as coronal section of the abdominal aorta, terminal abdominal aorta showing maximum narrowing of 13.5 mm. Final diagnosis, chronic kidney disease stage 3, Takayasu arteritis, pneumoangiography classification type 5, Indian Takayasu activity score of 30. She was started on 1 mg per kg steroids. Currently, she is tapered to 0.5 mg per kg steroids, and she is added on antiplatelets, statins, and anticoagulation in view of thrombosis of terminal aorta. Hypertension is controlled with 4 classes of antihypertensives. Digital subtraction angiography images. Here we can see the navigation of the left renal artery. It shows the severe narrowing of the ostium of the renal artery. However, post balloon angioplasty, there is increased caliber of the renal artery and the branches. On follow-up, on admission, creatinine was 4.58. Post angioplasty, there was a decremental trend 3.7, 3.2, and 3.3. Blood pressure was also had a decremental trend post stenting. currently on 25th when she was examined, her blood pressure was 160/90.
Hi, Nitin. That was a wonderful case. And so you have discussed the tracheostomy osteoarthritis very nicely. And what do you think the role of DTP renogram here with a creatinine of 4.5? Is it worth doing DTP renogram with this much of low GFR?
Madam, since she had activity score also, and there were signs of salvaging the kidney size were more than 9. So we wanted to know if there is improvement, there would be an improvement in creatinine after intervention. So to do an intervention, we wanted to know the functionality of the kidney. So for that reason, DTP renogram could be done, and hence it was done.
Get a good picture of the you may not get. Now, what is the cause for her renal failure? That sudden worsening from 1.5 to 4 milligram.
Madam, the cause could be either the patient is having renal stenosis, bilateral renal stenosis, so she had might have progressed.
Angiogram showed only left renal artery stenosis, no?
Right could not be visualized, madam. The contrast could not be.
Okay.
So,
and she was given AC inhibitor losartan.
Yes,
isn't it?
Telmisartan, madam. Along with
Telmisartan.
And diuretics, her creatinine worsened from 2.5 to 4.
That made you think in terms of possibility of a bilateral renal artery stenosis.
Yes, madam.
Because of the worsening with the ARB in the context of bilateral RAS. Isn't it?
Yes.
Okay. So that was a good case. I think it is a straightforward case of renovascular disease presenting as resistant hypertension. Handing over the mic to other panelists.
So Nitin, you are telling that right renal artery was not visualized.
There was a thrombus, madam. The contrast could not move to the renal artery, hence it was not visualized.
So could that be the reason for the acute worsening?
Yes,
because
madam.
actually your DTPR reliability is actually not that great, but as far as your CT is concerned, the parenchyma was taking up tracer. So which actually means that probably it's perfused. And with all the limitations of your DTP.
Collaterals could also be patent, hence DTPA could show the functionality.
There is some, definitely there is some background function, like it's not gone. The right kidney is not gone, right?
Yes, yes, ma'am. Yes.
Okay. So, like, how much was the gap between your immunosuppressive therapy initiation and stenting?
Immunosuppression was started in view of activity score being high and inflammatory markers being high, madam.
Okay, and when was the stenting done? Same setting, or like there was some gap?
Same, I mean, stenting, post-stenting only we had started, madam.
Okay. The tricky thing is basically this is a 49-year-old lady who had her symptoms started somewhere around 43 years of age, and as we all know, Takayasu is more of a disease of relatively younger age group, and she had a couple of uneventful pregnancies, which probably was the last pregnancy was in her 30s. So it's quite interesting that actually she had gone through all this without having an active disease. And most often the tricky question when you come across a patient in 50s is whether the disease is active or not. And unfortunately, there is no way. We can actually look at the HSCRP, ESR and all, but living in a tropical country with so much of infections around, I don't really know to what extent this is going to be helpful. The problem is whenever there is an activity, stenting is going to be a little bit hazardous because the wall will be pretty friable and it can actually lead to catastrophic events during the intervention. So yeah, in this case, obviously, you don't really have that much choices. You don't really know whether the disease is active or not, and you are in a difficult situation where you need to salvage the kidney also. So obviously, like it would have been better. Okay, anyway, things didn't turn out to be bad. Looks like there was an improvement after the stenting also. But in doubtful cases, it's always better to start immunosuppression. Wait for a couple of weeks so that the immunosuppression, like the inflammation settles down, and then go ahead with the stenting.
Hi, Nitin. This is Dr. Priya from Ped Nephro. So we also have our share of Takayasu arthritis in our adolescent females. I'm not sure how common it is compared to all of you all, but we get maybe 2 to 3 cases a year. I think this really highlights the importance. Clearly, this lady's uncontrolled blood pressure was missed or maybe not adequately evaluated for probably 10 years. And I think that the importance of taking 4-limb blood pressures, doing a good physical examination for pulses, which you did, and you really made your diagnosis based on absent pulses. So while we, of course, don't expect severe hypertension in our pediatric patients, and it's a must, I think it's probably a good point on physical examination to do pulses. And of course, this patient had a bruit as well, so that was helpful. The question I had was, in addition to steroids, was any other non-glucocorticoid immunosuppressant used?
There is plan of starting the second line of immunosuppressant, ma'am. Usually after reviewing the CRP and ESR after 3 months, we would take a call at starting on the second immunosuppressant.
She has very bad disease. She looks like she's going to need some.
Even the CT is showing features suggestive of fibrotic phase of the disease. So with multiple narrowing and aneurysmal dilatation. So
yeah, but it's interesting that her CRP and ESR are elevated still. Thank you.
Dr. Isha?
So I hope there are no more questions or inputs. So it was a good case presentation.
There are a few questions from the chat box, ma'am. I just
okay.
Does benign hypertensive nephrosclerosis exist? From Dr. Arvind Kanchi, sir.
For me, benign hypertensive nephrosclerosis is a histopathological diagnosis, madam. And usually the patients present with asymptomatic rise in creatinine. They usually have a very long history of hypertension. And it's a diagnosis of exclusion.
What do you think, ma'am? Renuka ma'am and Priyamvada ma'am, from your
Actually, benign hypertensive nephrosclerosis, there is a term which does not exist now. And most of the old chapters, old textbooks of nephrology used to have a chapter on benign hypertensive nephrosclerosis. Nowadays, we don't consider this diagnosis of benign hypertensive nephrosclerosis. It's only just as many of our old timers, we use still that, but I don't think it should be considered as a differential diagnosis in this case. Okay.
Yeah,
and the most important message I wanted to tell all the youngsters and the PGs who are listening to is, this patient had history of hypertension from 2014, and she was having uncontrolled hypertension from 2018 onwards. But unfortunately, as Dr. Priya Payas pointed out, the clinical examination was missed, and she had gone to multiple people, and all of them, and finally one nephrologist, were advised a renal biopsy, and she was scared to undergo biopsy, and she came for an opinion to us. And I think in the clinical examination, all this was found. So it is very important, even after multiple this thing, we have a modern imaging techniques and other things, it is always better to do a clinical examination in any patient of hypertension. In fact, any patient who presents with edematous illness also, we have to look into all the parameters which we are supposed to look in a patient of hypertension, which obviously was missed by the others. So this is a very important message I wanted to tell you.
What happened to the antihypertensive requirement? Was it decreased by Dr. Hardik Patil?
Initially, she was
Yes.
requiring nearly 5 class, ma'am. Now, currently, she is on 4 class of antihypertensive.
And was stent inserted after plasty by Dr. Arvind?
No, stenting was not done, madam. Only angioplasty.
And would DTP would be avoided if renal Doppler could also help by Dr. Hardik Patil?
Functionality of the kidney cannot be assessed in renal Doppler if we are thinking of stenting or plasty. So for that reason, we had done DTP to see the viability of the kidney.
Dr. Arvind sir has one more question. If the right kidney was normal in size, could more have been done to look at the plasty and stent there?
Usually in Takayasu artery,
Actually,
right
the plan was to do that, but right kidney, we could not negotiate in the stenosis was very tight. It could not be negotiated by the interventional radiologist. So probably we'll have to look into it again.
How will we proceed with transplant if she reaches end-stage kidney disease by Dr. Manju?
we can see that there is thrombosis and stenosis at multiple levels, even involving the external iliac arteries. So transplant would not be a good prospectus for this kind of patient.
In this particular case, there is an extensive involvement of aorta, including the abdominal aorta and the terminal aorta. There is a narrowing. We have not looked into the iliac arteries right now. If that is normal, we could have we can go ahead and plan a transplant in future if she goes into end stage renal failure. But presently, our this thing is to salvage this kidney itself.
Yeah, we had a couple of years back, we had a similar case. That was a young female who actually tried to conceive for 8 consecutive times. And she lost 8 pregnancies. And for the 9th, like she wanted another child and she came to us. She had actually extensive renal artery stenosis. We tried stenting, nothing could be done. But fortunately, her iliac vessels were normal. Both iliac vessels were normal. So we actually did an auto transplantation on her, and there was actually a drastic reduction in the requirement of antihypertensives. And finally, after 1 year or so of auto transplantation, she was able to have a successful pregnancy as well. So if the iliacs are intact, because aorta is anyway going to be gone, but if the iliacs are intact, these patients have some hope. But if iliac vessels are extensively affected, then probably things are going to be pretty bad.
And Priyambada, in this case, we also wanted to do an auto transplant on the right side, but there was a lot of collaterals there. So that is the reason why we decided not to. That it is not good to do a
you will not get a proper stump of the renal artery to anastomose. That's the problem.
Dr. Arvind sir is again asking, why was the stent not inserted on the left side? Was it the cost?
I think the stent was inserted. I don't know. Dr. Nitin, there was a plastic and stent inserted on that side.
Generally people go for a stenting.
Most
of the time, otherwise.
Only if it is FMD, they usually do only angioplasty.
No, but it is done in this case.
Stenosis, ma'am, in Takayasu arthritis. So studies have shown that plasty is more beneficial than stenting. So
no, Mr. Nitin, we have done a stenting in this case, as far as I know.
Ma'am, he also comments that the case shared by Dr. Priyambada ma'am was fantastic. Thanks, Dr. Priyambada ma'am, for sharing that your experience regarding auto transplantation. We have 2 questions to Dr. Prajwal from Dr. Sanjeev Sethi. He asks why no kidney biopsy was performed to confirm sarcoidosis.
Dr. Prajwal, are you there?
Yes, madam. Actually, patient was planned for kidney biopsy, but multiple renal calculi and right-sided hydronephrosis was there. So we thought already the diagnosis is there. So we'll wait and start the treatment because we had enough evidence to prove sarcoidosis in that case.
Dr. Ganesh Prasad has a question. He says, was Manto done in this patient? It can give clue between sarcoid and leprosy.
Manto was not done in this case.
Dr. Isha Tiwari, do you have any questions? We are coming to the end of the session. Dr. Isha, we're not able to hear you.
I think she is muted. Maitri, can you unmute her from your end?
I've asked her to unmute, ma'am. Yeah. Dr. Isha? Dr. Isha, we can't hear you. I think there is a technical glitch. Thank you so much, dear chairpersons, for sharing your valuable time with us and sharing all the insights. Thanks to all the postgraduate students, senior residents for sharing all the interesting cases from St. John's Medical College. I now request Dr. Suma Raju to propose the vote of thanks.
Very good evening, all. On behalf of Winkarnataka, it is my privilege to deliver a vote of thanks today on this first academic event tonight. I would like to take this opportunity to extend our sincere thanks to our guest speaker, Dr. Lillian Palmer. I'm not sure if she's here yet, but anyway, she gave such a wonderful talk today. It is indeed a very complicated and a volatile topic. Today, I felt like I understood everything. She simplified it and made it so easy. And thank you for that, Dr. Lillian Palmer, if you're still here. Next, I would like to thank the entire St. John's Nephrology Department, including Dr. Renuka, who inaugurated the session today, and the senior residents, Dr. Naveen, Dr. Prajwal, and Dr. Nitin, who presented such wonderful cases. It was academically stimulating indeed. It just feels like there's never a dull moment there, for sure. Fantastic cases. Next, all the chairpersons out there for taking their time off. I really thank you for that. And you made this event more academically enriching with your experiences. Last but not the least, Dr. Maitri Shankar, torchbearer of Winkarnataka. Sincere thanks to you for putting up all this and hosting this academic event tonight. I think this is just the beginning. Finally, the audience. I know it's Friday night, more options, but thank you all for attending this session. And a big shout out to Sachin out there, our back-end person, for hosting this webinar. Thank you all. Good night.
Thank you so much.
Good night to all.
Maitri, thanks, Siddharth. Thank you so much. Thank you.
So that was a wonderful event.
Yes.
Thank you, ma'am.
Thank you, Siddharth. Thank you so much.
So thank you and good night to all.
Good night.
Thank you.
Good night. Wonderful session.
Yeah, please
Very
watch
informative.
In India YouTube channel. This will be uploaded, and please share and subscribe the same.
Thank you.
Thank you. Thank you
Thank
so
you.
much. Thank you, madam. Thank you so much. Right. Bye. Bye.